In this lecture, we're going to be going over antidepressants, anxiolytics, and sedative hypnotics, and then we'll also be doing antipsychotics as well. This is going to be a little bit of a big lecture. For those of you who have experience in nursing, and especially with these types of drugs, it should be pretty easy to take care of. But if you've never been exposed to this before, it's a lot to take in. But we're going to try and make it as simple as possible. Okay, when it comes to treating depression, we have several different classes of drug: tricyclic antidepressants, monoamine oxidase inhibitors, selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, atypical antidepressants, and atypical antipsychotics. Now, with the exception of the atypical antipsychotics, the general theory is that any of these drug classes will be equally effective for the treatment of depression if you can get the patient to high enough a dose for long enough a time. The problem, of course, is that a lot of these drug classes, you can't get the patient to high enough a dose for long enough a time. Now, before we talk about the treatments itself, let's just talk very, very briefly about what depression is. Now, depression is a depressed mood, which means a lowered mood. A depression is a low space. So it's a low mood, loss of pleasure and interest in usual activities. And here's the key: it has to be sustained over time. Now, we're not talking about the DSM-5 in a lot of detail here. There are criteria that there are for different types of depression. We're not trying to diagnose depression. However, as nurses, we should be screening for depression. There are some subtypes that the DSM-5 recognizes, which includes major depression, clinical depression, subclinical depression, postpartum, and bereavement. Now, in the last slide, I said that we're not trying to diagnose, but we do need to screen for it. Every patient in the hospital, and really in the healthcare system, needs to have depression addressed, because patients in our healthcare system are often dealing with loss of functionality. They can't do things they used to do because of their new heart condition, their new lung condition. They lost a limb. They had a foot amputated. They broke a bone. Their loss of youth and feeling of control. You know, everyone feels on top of the world until they break a couple ribs. Then what happens? Loss of control. I can't even go to the bathroom by myself anymore. They might be dealing with a chronic illness for the first time. And that can be a 14-year-old. It can be a 45-year-old. It can be a 70-year-old. Altered sleep patterns and exercise patterns are associated with depression. And then altered role. I'm the one who's used to help providing for my family, and now I can't provide for my family anymore. I'm the one who's always done the dishes and done the food and done the this and done the that, and now, so all of those things can be associated with depression. The other thing we have to make sure is that we rule out bipolar and organic causes of depression. Patients may have depression, loss of energy, loss of feeling of, or depressed mood, not because of something going on in their brain, but because of something going on in their body. Classic example would be hypothyroidism. Anemia can also be another one. In men, loss of testosterone or hypotestosteronism. All of those can be potential causes for depression and more. Okay. You do need to know sticky caps for your test: sleep, interest, guilt, energy, concentration, appetite, psychosomatic symptoms, and suicidal ideation. You should know these cold. So if you take just the first letter of each word, you get sticky caps. These are diagnostic criteria from the DSM-5 for depression, and you should be able to be familiar with them and just ask patients, hey, have you had any trouble sleeping, or do you sleep more than you used to? Have you lost interest in your normal activities? Do you have excessive feelings of guilt? Have you had a change in energy, either more energy than usual or less energy than usual? Have you been having trouble concentrating? Have you had changes in your appetite, either more appetite or less appetite than usual? Have you been having any psychosomatic symptoms? So those would be symptoms that are associated with mood. And then, have you thought about killing yourself or anyone else? Collectively, we call those sicky caps. And just also wanted to mention that usually when a patient has depression, they sleep more often, but some patients have insomnia. That's more commonly called atypical depression. When it comes to appetite, most patients have a loss of appetite because they're not interested in things that make them feel good, and eating typically makes people feel good. So they will have a loss of appetite. However, some patients, when they're depressed, eat more, and that's, again, atypical depression. And then as far as energy goes, if the patient has more energy than usual, you're going to be suspecting that they could have bipolar disorder and not simply depression. And of course, suicidal and homicidal ideation is extremely important in today's age of very highly publicized mass shootings, which are often conducted by a person who is on depression medications. And we'll talk a little bit more about that when we talk about SSRIs. Okay, when it comes to depression treatments, we have cognitive therapy, which is basically thinking therapy, getting you to think differently. That usually involves a lot of talking. We also have behavioral therapy, which is doing something, so doing exercise, doing art, etc. We also have electroconvulsive therapy, which in not too distant past was considered barbaric and torture, and that was mainly because we weren't using good anesthesia practices. Modern ECT is done under general anesthesia. The patient is paralyzed, so when you electrically stimulate the brain, it actually causes seizures all over the body, and that caused a number of problems. Patients would have all sorts of musculoskeletal issues. They would bite down on the endotracheal tube. They would break their teeth, really nasty stuff. But now that we completely paralyze the body, you get all the good effects of ECT without having those horrible muscular side effects. So nowadays, ECT is considered a much better option. And for some people, they utterly swear by it. Then we have pharmacology. And in the old days, you would treat major depression for 6 to 12 months, and then you would wean the patient and taper them off. Nowadays, however, it seems like the patients are on the drugs long-term, forever. We don't really have any studies that shows what happens when you take a patient and leave them on the drug for 10 years. We're kind of in new territory there. We'll talk a little bit about that when we talk about some of the individual drugs. It's extremely important to distinguish between situational and transient depression versus true depression. And that's why bereavement, are they depressed or are they just sad, naturally sad, and they will get better? And one of the interesting things that we find, some psychiatrists will say, if you take a patient who has some sort of family or life event that makes them sad and they need to grieve, and they don't because they're on medications that prevent them from grieving, whether it's we put them on the medication at the time that the event happens or whether the event happens when they're on the drugs, that when they go off the drugs later on, part of the withdrawal process, they have to then go through the grieving process. And so you'll have a patient who they were on an SSRI, their father died, and they never grieved because they didn't feel depression. They didn't feel sadness because their father had died. When they go off the drug, now they have to cry and go through that bereavement process, sometimes even years later. So a really interesting thing. Not really sure what it means, but what we do know is that you can't cheat your own emotional needs. Okay, our first actual drug class is going to be tricyclic antidepressants, also known as TCAs. These are very old drugs. They are cheap. as stated before, they are theoretically effective if you can get them to a high enough dose for long enough. However, that is an extremely difficult thing because they have multiple actions, and as a result, they have a lot of side effects. We think that the primary therapeutic effect is through the inhibition of norepinephrine and serotonin reuptake, which in turn is going to increase the amount of norepinephrine and serotonin. Because of that, they've got a huge number of side effects. This is the type of drug that I heard one psychiatrist refer to as the sort of drug you wish your mother-in-law was on. So it's the kind of drug that you want your enemies to be on. Some of them have, now, again, we said they're not effective unless they're at high doses. So as a result, you're rarely going to see these actually be used as an antidepressant. They're more often used as either an adjunct for sleep or pain. So if a patient can't sleep, a lot of times they'll prescribe TCA that has drowsiness as a side effect. And if patients in pain, sometimes chronic pain or sort of nerve pain can sometimes be treated with tricyclic antidepressants. So the three drugs that you should know for this particular course are amitriptyline or Elavil. You'll often see that used for either restless leg syndrome or for sleep. The other is nortriptyline or Pamelor, and then finally Tofranil or imipramine. As you can see, there's a lot of adverse effects to these drugs. So typically, we just don't use them at high doses, which would be required for depression, most likely for smaller neurological issues. One thing I want to mention is at the bottom you see hypomania. All depression drugs have the potential to raise a patient with bipolar from depression and cycle them into mania. So it's extremely important that you tell patients who are going to be taking antidepressant medications, if this drug works and cures you in 2 or 3 days, it did not cure you. You actually have bipolar and it cycled you into mania. So you need to call your doctor immediately. And again, if you are using them at higher doses, you've got to start low, take a long time to increase the dose, and there you have it. Okay, next we have MAO inhibitors, monoamine oxidase inhibitors. If you recall from our lecture on epinephrine and norepinephrine, MAOs break down norepinephrine and epinephrine. So by inhibiting MAO, you're going to increase the amount of norepinephrine that is present in junctions in the peripheral and in the central nervous system. So as a result of that, they actually work pretty well, but they have high toxicity, and there's a lot of drug and food interactions. So they're typically considered a third-line therapy now that we have safer options. But they do work if you can get the patient to a high enough dose for long enough. In particular, you've got to avoid foods that are high in tyramine, and you can see a list of those foods, which are like, well, everything you'd actually want to eat. So because of that, those foods that are high in tyramine. Tyramine, in turn, is a precursor to norepinephrine. So if they eat these foods, they're going to get more norepinephrine production, which potentially causes hypertensive crisis, basically too much sympathetic response. Also, you've got to be extremely careful with these drugs and sympathomimetics. So patients should avoid phenylephrine and pseudoephedrine while taking MAO inhibitors. And then we have certain drugs like linezolid, which is Zyvox antibiotic, actually has MAO inhibition as a side effect. So patients who are on Zyvox should avoid the same things as patients on MAO inhibitors. As far as drug names go, Nardil and Marplan are some of the more common ones that are used. Okay, next we have selective serotonin reuptake inhibitors. These are relatively new drugs, although, I mean, 1987 is that's 30 years ago. But they are relatively new when you're comparing them to the older drugs like tricyclic antidepressants and Mao Inhibitors. They became the most prescribed class for depression very, very, very quickly, revolutionizing the treatment of depression. The very first drug was Prozac, fluoxetine, and there are entire books written about the subject, Prozac Nation, etc. So they block the reuptake of serotonin only, which is why they're called selective serotonin reuptake inhibitors. Now, it takes about 2 to 3 weeks before they begin to take therapeutic effect, and it can take up to 2 months for them to reach maximal effect. They can be used in addition to depression. They can also be used for anxiety, social phobia, obsessive compulsive disorder, and PDD, which is premenstrual dysphoric disorder, better known as PMS. When it comes to adverse effects, sexual dysfunction and weight gain are two of the most common adverse effects. Sexual dysfunction can affect both men and women. It actually affects women worse than men. And it's not necessarily erectile dysfunction. What it is lack of libido. So in women, it will manifest as anorgasmia. So they lose the ability to have an orgasm while on the drug. Weight gain can be very disconcerting and can actually add to the sexual dysfunction because people don't tend to feel very sexual when they don't feel very attractive, and they don't feel as attractive when they've gained 30 or 40 pounds. A life-threatening side effect is serotonin syndrome. It only occurs in the first 2 to 72 hours. And what happens is essentially by blocking serotonin reuptake, instead of having a small increase in the amount of serotonin, they have an enormous amount of excess serotonin. So much so that the serotonin begins to activate sympathetic receptors, alpha-1, beta-1 receptors, and basically causes an overload of fight or flight syndrome. So they can have high heart rate, high tachycardia, sweating, all of those things associated with sympathetic response. Withdrawal syndrome can also occur. So basically, you need to taper this medication down. You can't just suddenly stop taking it. Teenagers and college students are notorious for all of a sudden just stopping their medication, and that can cause all sorts of problems. Teen suicide, there is an increase in suicidal behavior, and actually we've seen in more recent years potentially homicidal behavior as well with patients who are on these drugs. Now, the older theory was that patients would have a loss of will or energy along with their depressed feelings. And as the treatment progressed, what would happen is the patients would regain their feelings of volition, their energy, before they regained their good feelings. So they still felt depressed, they still felt suicidal, but they didn't have enough energy or will to carry out their plan. Once they're on the drug, their will comes back and they're able to carry out their plan before their suicidal feelings go away. That was the theory, and I actually taught that theory up until about a year ago. Some newer research shows that what actually happens is that increased levels of serotonin are associated with increased impulsivity and decreased inhibitions. So patients will do and say things that they ordinarily wouldn't do. Have you ever had a thought cross your mind like, hey, I should do that? Oh, no, that would be horrible. I shouldn't do that. People will describe, like they just walk down the street and, that person, maybe I should punch them. Or maybe they have this overwhelming urge, like maybe I should yell or cuss at someone, but they don't ever do it because they are properly inhibited. No, that would be dumb. That would be stupid. There would be problems. I shouldn't do that. But in a patient who's on SSRIs, they are much more likely to follow through on those impulsive thoughts that come through their head. So that's also would explain not only the increased suicidal tendencies, but also the increased homicidal tendencies. The bottom line when it comes to teens is that teens who are on SSRIs need to be very, very closely supervised. And then finally, my own experience with patients who are on SSRIs, they will often complain of feeling flat or unresponsive. So yes, I don't feel depressed anymore, but I also don't feel happy. So I went to a birthday party for my for my son, and I didn't feel anything. And so a lot of patients actually want to go off of their SSRIs because of that feeling flat or unresponsive. Some of them also complain about disturbing dreams, especially in the early stages of taking the medication. Now, whether that's associated with the decreased inhibitions, I'm not sure, but I often hear patients tell me about that. While we're on the subject of serotonin and impulsivity, I just want to mention something that we've recently found out in research. There's something called a high neurotic. So a person who scores high on the neurotic scale is someone who typically is very obsessed with a lot of details. And as it turns out, that kind of person has less serotonin in their brain. So if you say you were almost hit by a car while you're driving into school, a lot of people would have an epinephrine response, and then they would freak out a little bit, feel shaky, all of that. And then serotonin would come in, calm the patient down, or calm the person down. And then by the time they got to work, they'd be like, oh my gosh, this horrible thing happened. You would never guess what happened to me. But they're pretty much over it. Whereas a high neurotic doesn't have as much serotonin in their brain. And as a result, they are much more, they don't have the ability to deal with that. So the entire day for them is ruined because of this thing that happened early in the morning. And so if you don't understand that, if you work with someone who's a high neurotic, they're like, oh my gosh, this person is always going so overboard. They're blowing everything out of proportion. And so it actually turns out that people who are high neurotics are very good at avoiding situations that are problems because they can't handle problems that well. They are very good at thinking of ways to avoid them altogether. Meanwhile, someone who is very low in the neurotic scale, someone who's got a lot of high serotonin, is like, yeah, no big deal. I can deal with that. So when you're working in a mixed situation where you've got people who are high neurotic and people who are low neurotic, they have a tendency sometimes to be very at each other's throats. You don't care about everything. Oh, you take things too personally. And so if you can actually understand that you have your own strengths and weaknesses, you can let the person who's the high neurotic work to their strength of preventing those situations, and you can let the person who's the low neurotic work to their strengths in dealing with problems once they do occur, despite the high neurotic's attempts to prevent them from occurring in the first place. And finally, I wanted to just reiterate the caution that I said about with tricyclic antidepressants, that all of the antidepressant medications have the potential to cycle a patient with bipolar depression into mania. So if a patient says, hey, I've been cured in 2 or 3 days, you're a genius. They didn't get cured. They had bipolar and they went from depression into mania. So that patient needs to call the doctor again, come back in, and be treated now for their mania. Okay, here's some very common agents: fluoxetine, sertraline, paroxetine, fluvoxamine, citalopram, and escitalopram. All right, so let's just briefly talk about the difference between citalopram and escitalopram. So citalopram, or Celexa, was the original drug, but it's a racemic mixture. So drugs come in mirror images of each other. When you create a biochemical molecule, it can come in a left-hand configuration and what's called a right-hand configuration. So if a drug is an equal mixture of left and right-handed drugs, that's called racemic. So you can actually separate out that mixture into a left hand only or a right hand only. Now, in some drugs, one of the hands will be inert. It basically doesn't do anything. And so usually what we'll do is we'll give that as a racemic mixture. But sometimes what we discover later on is that the other hand that we thought was inert is actually causing side effects or inhibiting the therapeutic effect. And if we separate out the two hands and give it separately, we actually have a more effective drug with fewer side effects. So in the case of S-citalopram, the S means left hand. S in Latin is short for sinister, and then D is short for dexter. Sinister is left, dexter is right. So if you ever hear of dextrose, what you got is the right hand of a racemic glucose mixture. So dextrose is the right-handed side only of glucose, and then S-citalopram is the left-handed side of citalopram. By the way, citalopram recently came into the limelight in June of 2017 because of that girl who encouraged her boyfriend to commit suicide. She was actually taking citalopram, and so the blame was partially put onto that for her behavior. Going back earlier, with the impulsive behavior, it is quite possible that it played a part in her texts that she's telling her friends, or telling this guy, hey, you got to get back in there. You can't be doing that. So ordinary person would most likely say, you shouldn't kill yourself, blah, 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 go get help. But a person who's very impulsive as a result of their drugs might be more inclined not to do that. Okay, so some teaching points when it comes to dealing with patients who are on SSRIs. The therapeutic delay is an important one. You don't take this and feel better that same day. It's going to take a little while to build up. Warn them about signs and symptoms of serotonin syndrome and the time frame. So remember, you're going to have signs of sympathetic activation, and it's typically within the first 72 hours. Withdrawal syndrome, don't stop taking it suddenly. They need to taper down. And then the sexual side effects and weight gain are usually the number one reasons why people stop taking the drugs. And of course, we should probably mention the suicidal, homicidal ideation, especially since it's so in the news. Now, as many people who are on these drugs and as few incidents as there are, it's fairly safe to say that it's a relatively rare occurrence. However, it's a big impact when it does occur, so it's important to make sure our patients know about these. And if we're dealing with teenagers and kids, the parents need to know as well. Okay, next we have serotonin norepinephrine reuptake inhibitors. So these drugs inhibit the reuptake of not only serotonin, but also norepinephrine. So they act kind of like a combination of a MAO inhibitor and a selective serotonin reuptake inhibitor, but they're going to be safer than MAO inhibitors. But they're going to be less safe than a selective serotonin reuptake inhibitor. So they can cause mild excitation, which can be associated with anxiety as an adverse effect. And the drugs that you're going to need to know are venlafaxine, desvenlafaxine, and duloxetine. Now, desvenlafaxine is the active metabolite of venlafaxine. So basically, venlafaxine is a prodrug for desvenlafaxine. Now, even though anxiety is a potential adverse effect for these drugs are also approved to treat anxiety as well as depression. They also have less weight gain because of the norepinephrine and the mild excitation. So they're sometimes preferred for patients who easily gain weight or who are unhappy with the weight gain on an SSRI. Next, we have atypical antidepressants. These are antidepressants that we don't really put into a drug class per se. They're usually single agents. So sometimes we'll say it's a new drug class, but there's only one drug that works that particular way. So one example is bupropion or Wellbutrin. And what it is a dopamine reuptake inhibitor, increases the amount of dopamine in the brain. Increased dopamine is associated with feelings of happiness. Dopamine is also associated with impulsivity, concentration, and addictiveness. So sometimes this drug, in addition to being used for depression, will be used to help patients concentrate, and it can also be used to help patients stop addictive behaviors such as smoking. Wellbutrin is the main brand name, and when it's used for stopping smoking, it's called Zyban. Bupropion typically comes as a sustained release medication, but you still have to take it twice a day. It can cause increased energy levels and potentially some anxiety. You typically don't want that second dose to be taken after 4 o'clock in the afternoon because it can potentially disrupt the patient's sleep if they take it too late in the afternoon. Bupropion causes no sexual side effects and does not cause weight gain. If anything, it may cause slight weight loss. So patients really typically love this drug compared to the SSRIs and SNRIs because of those lack of side effects. And they also have more energy. And remember, one of the symptoms of depression for most patients is a loss of energy and sleeping too much. So, it's a really great drug in that a lot of its adverse effects treat depression symptoms. An important adverse effect of bupropion that we need to know about is it has the potential to decrease the seizure threshold, making it more likely for patients to have seizures. So patients who have history of seizures and children, and really typically anyone lower than 18 years of age, should not be taking bupropion. Okay, nifazodone and trazodone are members of the same class, and they work kind of multiple ways, but we think the primary way they treat depression is by inhibiting serotonin reuptake. They cause significant amount of drowsiness, and trazodone is actually usually used as a sleeping aid in elderly patients. Then mirtazapine or Remeron is sometimes called a quadra or tetracyclic antidepressant, and it works by increasing the amount of norepinephrine and serotonin and has a number of adverse effects. It has a very strong antihistaminic effect, which is associated with extreme drowsiness. Now, this is an interesting drug in that the longer you're on it and the more you increase the dose, the fewer the side effects you get. So it's actually the worst when you first start taking it, but will get better over time. Okay, so here you can see everything I said on the slide before, so refer to the slide before. Okay, and then finally we need to talk about atypical antipsychotics. These are not used for depression alone. They're used, one, to potentiate antidepressant drugs, such as the SSRIs or SNRIs. They're also used for depression with psychotic features. We'll talk about psychosis in a few minutes, but loss of touch with reality, which is going to be either delusions or hallucinations. And then we also use them for bipolar depression. One of the common adverse effects for patients who have bipolar depression when they're on regular antidepressants is it cycles them into mania. So the atypical antipsychotics can help prevent that cycling into mania. Also commonly used in teenagers who need antidepressants, because a lot of times teenagers with depression don't simply have unipolar depression, they have bipolar depression. So you can see some common agents there. And again, we'll talk more about these when we talk about the typical antipsychotics. Next, we have sedative hypnotics, which are drugs that are going to be used to treat patients who need to either calm down or need to fall asleep. And so we've got a couple different groups of drugs here. Okay, benzodiazepines, or benzos for short, are safer and have lower abuse potential than other central nervous depressants such as barbiturates, which we'll talk about in a little bit earlier. Barbiturates were invented before benzodiazepines, so they were a marked improvement over barbiturates. Now, the way that they work is they potentiate the neurotransmitter GABA. GABA is always an inhibitor. It always causes a reduction in brain activity. So the way this basically works is by causing your brain to kind of self-regulate downward and reduce neural activity. All the benzodiazepines are controlled substances because they have abuse potential. I wanted to mention that the finite action means that there's a ceiling on the maximal efficacy of benzodiazepines. That makes them relatively inherent unless you combine them with other central nervous system depressants, such as alcohol. And that is one of the problems, is that people who take benzodiazepines recreationally often mix them with alcohol. And that, or opioids, or also even antihistamines, because all of those have the ability to, in combination with the benzodiazepines, cause death. If you remember the death of Heath Ledger, he actually had relatively low doses of a benzodiazepine, an antihistamine, and I want to say an opioid. So it was relatively low doses of all three, but that combination was enough where it caused him to stop breathing, and he died. Okay, effects of benzodiazepines in the central nervous system. We're going to reduce anxiety, and that is one of the major reasons why we use benzodiazepines is as an anxiolytic. They promote sleep, so we can use them as a hypnotic to help patients sleep. They also act as a muscle relaxant, although not all of the agents are used for that. And then they also can cause anterograde amnesia, which means that the person doesn't remember what happened after they took the drug. In common parlance, this would be called a blackout. So think about it in terms of drinking alcohol. The person drinks alcohol, and then they don't remember what happened for the rest of the evening. That is what makes benzodiazepines relatively, I don't want to say good, but it makes them effective drugs for date rape because the person doesn't remember what happened after they took the drug. It also makes them good for anesthesia and surgery, and midazolam or Versed is going to be primarily used for its ability to induce anterograde amnesia for what we call conscious sedation. Then under cardiovascular, if you take benzodiazepines by mouth, there's really no cardiovascular. However, when given IV, they can cause hypotension and potentially cardiac arrest, so they need to be administered relatively slowly. And then in respiratory, they are weak depressants by themselves, but they are strong depressants when given in combination with other central nervous system depressants. Okay, most of the benzos are well absorbed by mouth. You can also give them IV, most of them anyway. As far as metabolism goes, most of them have active metabolites, and the duration can be wildly different among agents. So, for example, although flurazepam only lasts 2 to 3 hours, its metabolite can last 50 hours. Okay, so as I mentioned before, we can use benzodiazepines for anxiety, for insomnia, for seizures, muscle spasm, alcohol withdrawal, that is delirium tremens prevention. And this is something that it's important to understand, that there are different stages of alcohol withdrawal, and delirium tremens is not the same as seizures. I'll post a link to an article that shows the difference between the different types of withdrawal, and you will need to know that for your test. We've got panic disorder, surgery, and with surgery it can be either conscious sedation or induction of anesthesia. Okay, as I mentioned before, you need to know the difference between the different stages of alcohol withdrawal. So there's the link to the article I mentioned and also the major stages. It is delirium tremens that is life-threatening. Withdrawal seizures are not life-threatening, although not desirable. Okay, as adverse effects go, we already mentioned some of these earlier, but again, in the central nervous system, drowsiness, lightheadedness, concentration, and motor vehicle accidents. When it comes to amnesia, it's anterograde, and then you can have paradoxical effects where a person has the opposite of the expected effect. So instead of calming them down and causing them to sleep, they can actually become very stimulated and aroused and agitated. That is more likely to occur in elderly folks and in young children. Can cause respiratory depression, although by itself it's mild. The potential for abuse and addiction. And of course, don't use this in pregnant women. Okay, here are some common benzodiazepines that you'll need to know for your test. Diazepam, lorazepam are very commonly used in the hospital. Lorazepam is going to be more common than diazepam. Alprazolam is used only for anxiety. Clonazepam can be used for seizures as well as anxiety. Chlordiazepoxide is a very long-lasting benzodiazepine and is often used for DT prevention. Temazepam, Restoril gives you a hint as to what it's used for. It's exclusively used for sleep. And then midazolam or Versed is used for conscious sedation. It has a very, very short half-life, only about 5 minutes. So within 20 minutes, it's completely gone from the patient's body. Now, when used by itself, it is the same as any other benzodiazepine, just short-acting. When given in combination with an opioid, it produces conscious sedation, which is technically anesthesia, and it is illegal. It's outside of the scope of nurses' practice to give conscious sedation. So if you have a doctor who says, here, just push a little bit of that Versed, pushing Versed is within your scope of practice. Pushing Versed in combination with an opioid is administering anesthesia. So unless you're a nurse anesthetist, don't do it. Okay, next we have drugs that are benzo-like drugs. They are similar to benzodiazepines and they upregulate GABA in a similar manner, but they're not actually benzodiazepines. These are all controlled substances, just like benzodiazepines. So you've got zolpidem or Ambien, Zaloplan or Sonata, and Zopiclone, which is Lunesta. That's pretty much it. All of them have the potential to cause confusion in the middle of the night, especially in elderly folks, just like benzodiazepines do. So they're not necessarily the best for older patients. Doubling the dose is not going to prevent waking up in the middle of the night. If patients wake up in the middle of the night, they are more likely to be confused. When it comes to taking these drugs, typically the way that you want to take them is you have completely done all of your nightly routine. You brush your teeth, you've done all that stuff. You're ready to go to bed. You take the drug, go to bed. You don't take the drug and then watch TV for an hour and then go to bed. You take the drug, go to bed. I also wanted to mention that back when I was working as a nurse practitioner in family practice, we would have drug reps come around, and all of the drug reps for Pfizer were all taking Ambien, and they all swore by it. They're like, "That is the best sleep you've ever had." Now, I've never actually taken Ambien myself, so I can't corroborate that story. But according to them, it was the best thing they'd ever done because they just had such restful, awesome sleep. Barbiturates are older drugs, and they work similarly to benzodiazepines in that they upregulate GABA, but they can also directly stimulate GABA. And that means that there is no ceiling on their effects, which means that they are very dangerous drugs. They are highly addictive, and as far as therapeutic uses go, it's pretty much seizure and anesthesia induction. In the older days, before we had benzodiazepines, they would sometimes be used for sleeping aids, but benzodiazepines are just so much safer that there's just no reason to use them for that. The most common agent on the market nowadays is phenobarbital, and it's usually going to be used more for its seizure activity than it will be as for anything else. Some other hypnotics include melatonin, which is a hormone produced by the pineal gland of the brain, and that provides what we know as a sleep cue. So if you've ever been sitting down, doing something. Maybe you're watching TV or reading a book, and all of a sudden you just feel really tired. I'm so tired. I could go to sleep right in a second. And you know that if you went to bed right that second, you would fall asleep in a couple minutes. But you don't go to bed. You just keep reading or watching TV. And then about half an hour later, you're like, see, I'm not tired at all. And you're not tired again for a couple hours. Maybe now it's 1 a.m. before you're tired again. That feeling of tiredness is produced by melatonin and is called a sleep cue. When you miss your sleep cue, it could be hours before you get it back. Some people never get it back that night, and they're never really tired until the next day. You can also use Ramelteon, which is brand name Rosarum, and that is a melatonin agonist. It's not actual melatonin, but is a drug that stimulates melatonin receptors. And then you've got first generation antihistamines. All of these have a lot of side effects, including drowsiness. So diphenhydramine is Benadryl, hydroxyzine, fairly commonly used for that, and then doxylamine, which is the antihistamine found in NyQuil. Now, diphenhydramine and doxylamine are both marketed over the counter as sleep aids. And then hydroxyzine is prescription only. Now, even though this is a pharmacology course, we're going to talk about some non-pharmacologic sleep issues, because this is one of the areas where the non-drug remedies work as well or better than most of the drugs. And these are things that are really easy to implement. So first we have behavioral and cognitive approaches. So the first one is exercise. Sometimes people just aren't tired because they have too much energy. They haven't done enough physical activity that day to earn their tiredness. So exercise is a very good way to increase sleep. But you can't do it too late in the evening because exercise causes a stress response, sympathetic response, and you want to have the patient make sure they have enough time to calm back down before they're trying to go to sleep. Otherwise, they can be overstimulated rather than tired. Avoiding alcohol, caffeine, and nicotine. Now, alcohol helps people go to sleep because it's a central nervous depressant, but it can actually impair the quality of sleep. So avoid alcohol. Caffeine should be obvious. Some people can drink caffeine and then go to sleep, no problem. I am one of those people. My wife, on the other hand, if she has caffeine after about 10 in the morning, she can't sleep later that evening. And then nicotine can also interfere with sleep. A routine is extremely important. You try and go to bed at the same time every night. We talked about the sleep cue. Don't miss your sleep cue. Make sure you go to sleep when you have your sleep cue. Relaxation and meditation practices, whether it's taking a warm shower, drinking some warm milk, meditating, or massage, whatever helps you to relax and get in that relaxed state will help you to sleep better. And then a sleep restriction is actually what you do is So in sleep restriction, what you do is you only get in bed to sleep. You don't get in bed to study. You don't even go in your room a lot of times to study or relax, watch TV, read a book. The only time you're in bed is when it's time to sleep. And if you can't sleep, then you get up and you get out of bed. So if you find yourself that you're just wide awake and not really sleeping, then you get up. If you wake up in the middle of the night and you can't sleep, you get up and do something else, and then you go back to bed to sleep. That can be very, very helpful. Another thing that can help is reducing light, especially blue light, late at night. So if you look at the sky is blue. If you wake up in the morning and you go outside, you'll be exposed to blue light. Blue light helps our bodies to know that it's daytime and we should be awake and alert. Red light is more common in the evening. In the old days, when you think about a fire, the sunset, and that is associated with telling your body it's time to go to bed. The problem is all of our electronic devices have these very bright bluish screens on them, our iPads, laptops, computers, iPhones, etc. So There's two approaches. One is you can install a program such as Twilight or Flux on your computer or your phone or tablet, which will, as it becomes later at night, will turn your screen redder so that you're having fewer blue tones, more red tones. Another thing you can do is wear what are known as gamma blockers. These are eyeglasses that prevent blue light from coming through your eyes. Is going to turn everything that's kind of slightly yellowish tinge, and that can also help prevent the blue light from interfering with your sleep cycle. And then finally, I want to mention you can also use an app that can help you sleep. It can monitor how well you sleep, and then it can try and wake you up when it's when you're in the middle of a sleep cycle or at the end of a sleep cycle before you go back to the next sleep cycle. So if you ever woken up at 4 in the morning and you're like, hey, I'm not really tired at all, but then you wake up at 7 in the morning and you're like, so tired, I can't get out of bed. The thinking is that you woke up in between sleep cycles in the middle of the night, and that's why you didn't feel tired. But when you woke up at 7 in the morning, you were in the middle of a sleep cycle, and that's why you feel groggy. So rather than using an alarm clock, which is just set by time and has no idea of what your sleep cycle is, an app like Sleep Cycle, which monitors how deeply you're sleeping, can make sure you wake up outside of a sleep cycle. So it'll wake you up a little bit earlier, a little bit later as needed, so that you wake up refreshed as opposed to groggy. Okay. When it comes to anxiety, it's important to understand there's two different types of anxiety. There is generalized anxiety and there is situational anxiety. If a person can tell you what they're anxious about, they have situational. If there is no reason for them to be anxious, they're just anxious. That is generalized anxiety disorder. Now, generally speaking, situational anxiety can be dealt with on a case-by-case basis. So you can use a PRN medication such as a benzodiazepine. Generalized anxiety disorder, although you can use benzodiazepines, it's generally better not to use PRN medication for them. It's better to use something like a selective serotonin reuptake inhibitor that you take all the time. So SSRIs can be used for generalized anxiety, as well as certain situational, such as panic disorder, obsessive compulsive disorder, social anxiety, and PTSD, post-traumatic stress disorder. So just a couple words about some of these things. Obsessive compulsive disorder is where there's a thought that keeps recurring in the brain. That's the obsession. And then there is a compulsion, which are behaviors that the patient does in order to avoid the obsession. And the problem is that it doesn't work. And what's interesting about patients with obsessive compulsive disorder is that they actually know that those behaviors don't help prevent the obsession, but they do it anyway. So here's a classic example. I had a friend whose obsession was thinking about people dying of HIV and AIDS in Africa. And so she would go to the store to buy, now it's a very mild case, but she'd go to the store to buy shampoo. And if she touched one of the shampoo bottles and thought about HIV and AIDS, she couldn't buy that particular one. So she'd have to touch every single bottle in the store until she didn't think of it, and then that's the one she could buy. Obsessive compulsive disorder patients are a lot of times obsessed with cleanliness and routines and rituals. And these rituals are designed to try and prevent the obsession. Of course, it doesn't work. Now, a related but different disorder is obsessive compulsive personality disorder. And that is a person who is obsessed with perfection. Now, the major difference is these people think that their obsession is a good thing, and they think that everyone else is wrong for not sharing it. So they'll make everyone else around them miserable with their obsession, with being perfect and, not they think that everyone else just has low standards. Post-traumatic stress disorder gets a lot of play in the news and in movies, and it's very, very rarely manifested in that typical, where you go to wake someone up and they're choking you because you're the enemy. That's very rarely how it manifests. Usually what PTSD is just an overwhelming emotion that is kind of inappropriate for the situation. So what happens is they can't handle ordinary things because of those overwhelming emotions. And that can be ordinary situations like, say, going to a bus station and being surrounded by all those people. They feel that they can't handle that emotion. It's very, very different than what you see in the movies, you know, we're waking up in the night with a gun, and that is very uncommon. Okay, other anxiolytics, buspirone or buspar. There's no sedation to it. There's no abuse potential. There's no interaction with alcohol. All sounds fantastic, but it develops slowly. You got to take it for at least a week before it actually begins to work, and it's going to take several weeks to reach its full potential. So never take this PRN. It's only approved for what's called short-term therapy, which is about up to a year. You can also use beta blockers, and that is going to be primarily for performance or test anxiety. So if the thought of something causes you to be anxious and you get your heart all going and you've got the heart rate thing and your hands are shaky and you're experiencing sympathetic response, beta blockers can actually help with that. Okay, next we're going to talk about antipsychotics. Now, before we can talk about the antipsychotics, we need to talk ever so briefly about psychosis, which is a loss of touch with reality. And there are two major ways that it occurs. First is sensory, and that is going to be hallucinations, where you have sensations that aren't there. They can be auditory, voices, and they can be visual. Auditory is far more common than visual. You can also if a patient is experiencing these, one of the very important things to do is ask, are the voices telling you to do something? It's often called command voices. So if you're just hearing people, if you're just hearing voices, that's very, very different than hearing voices telling you to do something. Also, ordinary people can have hallucinations and just not realize it. So you think you hear the phone ringing and it turns out the phone isn't ringing. Well, you actually had a hallucination. Visual hallucination that is very, very common is a mirage. But again, those are relatively ordinary, but we're talking about is something that is beyond that. Delusions are changes in thought patterns, and they are usually either grandeur or paranoia. So people with delusions of grandeur will often say that they are God or Jesus or Gandhi or some great historical figure. Paranoia is thoughts of they're out to get me. Now, the most important thing to remember about paranoia, if they really are out to get you, it's not paranoia. So sometimes patients with paranoia will say they're out to get me, but they don't know who they are, or they'll think that people are putting thoughts into their head. This is where you get the tinfoil hat idea, that patients think that someone else is putting thoughts in their head, and by lining their hat with tinfoil, they can prevent those thoughts from being put into their head. The thoughts are actually being generated by their disease. So some diseases that are commonly associated with psychosis, you've got schizophrenia, bipolar, and extreme mania is sometimes associated with psychosis, and then depression, usually severe depression. Okay, when it comes to schizophrenia, we usually delineate the symptoms into positive and negative symptoms. So positive symptoms are symptoms that a patient should not have. So delusions, hallucinations are the psychosis. And then there are negative symptoms, which are ordinary behaviors or features that a person doesn't have. So in the case of the ones on the screen, alogia is when a person doesn't talk very much. So ordinarily you'd expect a person to talk, but a person with schizophrenia who has a negative symptom might not talk, or they answer with just one-word sentences, one-word answers. So they're kind of like a teenager. Avolition is lack of will, so they don't have the ability to do something. It's kind of like they're depressed in a sense. Anhedonia is the inability to enjoy pleasure. So these would be things that an ordinary person can do, but the person with schizophrenia can't because of the negative symptom. Negative symptoms are often caused by medications that we're treating the positive symptoms with. And then finally, there are some cognitive symptoms associated with schizophrenia, such as memory issues and lack of attention. Now, there are two generations of antipsychotics. First generation, typical, and second generation, atypical. So the typical ones have a very strong affinity for dopamine D2 receptors. They are very, very strong blockers of dopamine. We separate them into high, medium, and low potency drugs. So the high potency have the most effect on, the lower doses. They have a much stronger effect on the receptors. The medium have a middle one, and low have low. These are highly associated with extrapyramidal symptoms, which we'll talk about in a second. And they also have fairly strong risk for sedation, orthostatic hypotension, elevated prolactin, and then elevated QT interval, which can cause dysrhythmias. Now, the second generation are known as the atypicals, and we actually talked about these a little bit earlier when we talked about antidepressant medications. They have less affinity for D2, and they have more affinity for serotonin. So they have less likelihood of EPS, but they also affect histamine, muscarinic, and alpha receptors. So they have other side effects, but generally they have less side effects than the first generation. And the most important thing is there is less risk of extrapyramidal side effects. From the first generation antipsychotics, haloperidol or Haldol is probably the most commonly used one, but there are some others. Chlorpromazine or Thorazine was the very first one ever discovered, and fluphenazine is also fairly common. So the extrapyramidal side effects. Movement in your body is controlled by a combination of stimulation from acetylcholine and inhibition from dopamine. When you block dopamine, you block the inhibitory signal. So think about taking your hand to your mouth. So you're going to feed yourself. You've got to contract the biceps, and you have to relax the triceps. So imagine if you tried to bend your arm to your mouth, but you didn't relax the tricep. Well, you see the issue. So dystonia is the first one, where you've got a patient who's got too much muscle contraction. They're having cramps, and that's because they're losing the inhibitory effect of dopamine. The next one is akathisia, which is rocking back and forth. So the patient's going to be rocking uncontrollably. You can point it out, and they might stop for a second, but then they go right back to the rocking behavior. Pseudo-Parkinsonism. Parkinson's disease is actually caused by loss of dopamine neurons in the extrapyramidal tract. So if you're inhibiting dopamine, you can actually cause Parkinson's symptoms. So the patient will have tremor, they'll have loss of facial motor control, and they can have postural instability, so they can't walk as well. And then tardive dyskinesias are repetitive behaviors. So one of them is lip smacking. So patients might be going, and they aren't even aware they're doing it sometimes. It's these repetitive behaviors. Sometimes their tongue will seem too big for their mouth, and their tongue will just kind of be rotating around. It's kind of like a camel chewing its food. These are involuntary facial movements that are caused by the extrapyramidal symptom. Now, the interesting thing about these extrapyramidal symptoms is that they have the potential to become permanent. So you take the patient off the drug and they keep doing it. Extremely nasty side effect. If patient ever gets them, you want to discontinue the drug immediately. While we're talking about extrapyramidal symptoms, I wanted to mention when it comes to the dystonia, remember the dystonia is caused by an imbalance between the acetylcholine and dopamine. So you can actually treat dystonia by giving an anticholinergic. So you lower the amount of dopamine in the body, or dopamine effect in the body, but you also lower the amount of acetylcholine. The drug of choice for that is called benztropine or cogentin. All right. These drugs, especially, haloperidol is one of the strongest typical antipsychotics and is often used for ICU psychosis. Now, one of the interesting things about ICU psychosis is we know what causes it, and we know that it's going to be relatively short term, and it's situational. So haloperidol is often used for the psychosis, but sometimes used inappropriately, used for agitation and used to calm patients down. But haldol is not a sedative, even though it can cause sedation. It's not meant for that. So nowadays, quetiapine is actually, which is one of the newer atypicals, is becoming preferred because of its side effect profile. So fewer side effects. And there we have it, most of the drugs for depression, anxiety, sleep, and psychosis.